Hello and welcome to the first in the series of pathology podcasts developed by SWCCG. These podcasts are designed to provide primary care health professionals with information and insights from experienced consultants on how to effectively investigate different conditions through pathology. Today we'll be exploring thrombophilia and anaemia testing with Worcestershire acute consultant haematologist Dr. Mark Crowther. Dr. Crowther has been at Worcestershire Royal Hospital for the past 6 years. Thanks for joining me, Mark. If we start with thrombophilia testing, one of the key clinical questions for many primary care health professionals is around the management of anticoagulation. To draw upon a practical example, I recently saw a 40-year-old gentleman who's had 3 months of anticoagulation for a DVT following a fractured femur. When can I stop anticoagulation?
For the initial treatment of a DVT, 3 months of anticoagulation has been shown to be as effective as 6 months and better than 6 weeks. After that, we have to weigh the risks of stopping anticoagulation, i.e. recurrence of a clot, against the risk of bleeding if they were to remain on the anticoagulant. The best determinant of risk of recurrence is whether the clot was provoked or unprovoked. If it was a provoked event, like this case due to the fracture, the risk of the recurrence is about 4% per year and probably plateau out at about 10 to 15%, meaning as long as the provoking factor is removed, there's no indication for long-term anticoagulation. This is even more so with post-operative clots, where the recurrence rate is less than 1%. Although preventative measures should be taken if the patient is exposed to another possible provoking event, for example if they require an operation. The one provoking factor that I haven't mentioned, which is treated differently, is cancer. If a patient has a malignancy, the risk of recurrence is much higher, and it's recommended they remain on anticoagulation, ideally with low molecular weight heparin, until the cancer is in remission. DVTs provoked by indwelling lines and intravenous drug abuse probably need only 6 weeks of anticoagulation.
Thanks, Mark. So what is the actual bleeding risks on anticoagulation?
Most of the information comes from patients on warfarin. The new oral anticoagulants are likely to be slightly less, but still come with an appreciable bleeding risk. I usually quote for young fit people the risk is approximately 10% per year of a bleed, 1% per year of a major bleed, and 0.1% per year of death. But as you know from various bleeding scores available, the risk increases significantly if you add in renal dysfunction, alcohol excess, hypertension, old age, and previous bleeds, etc. For example, Hasbled's score of a 70-year-old with a creatinine of 250 has a yearly risk of major bleeding of 4.1%. We also have to remember that intracerebral bleeds may lead to significant disability.
What about if this patient had an unprovoked event?
This is a lot harder. The risk of recurrence for an unprovoked event is about 7.5% per year, with about a third of patients overall having another event. When we also count in the risk of post-phlebitic syndrome, which happens in about a third of patients from DVT, and death and pulmonary hypertension following a PE, the risk balance of continuing anticoagulation is quite finely balanced. There are a few cases where long-term anticoagulation is definitely indicated. The first is antiphospholipid syndrome, so patients with an unprovoked event should have their antiphospholipid antibodies checked. This can be done while on anticoagulation, and their lupus anticoagulant performed when they stop their anticoagulation. Positive results need repeated 12 weeks later to confirm their persistence, so it's probably better to discuss any positive results with haematology and decide on anticoagulation while awaiting the second result. Patients tend to recur with the same type of clot that they had before, so a second reason for long-term anticoagulation would be a massive PE or a previous PE with lung disease, such that another PE would either be another massive one or likely to cause a catastrophic reduction in their lung function. Severe post-phlebitic syndrome, especially if there is residual clot, would make me err towards long-term anticoagulation, as this is a risk for recurrence. For the majority of patients, there is no good ways of determining their risk of recurrence. Inherited thrombophilia tests do not help, and therefore I usually take the view that the majority of patients will not recur, so why expose them to anticoagulation? There are some scoring systems being validated, and these may help in the future. They tend to use age, sex, and the patient's D-dimers.
Is thrombophilia testing not helpful when giving advice to family members?
In unprovoked events, about half of all patients will have a detectable inheritable thrombophilic abnormality. As mentioned before, this does not help with their risk of recurrence. First-degree relatives have an increased risk of a clot regardless of whether or not they inherit the known abnormality. This probably means that there are a host of other inherited thrombophilias we don't know about. So regardless of whether they are a carrier or not, the advice is the same. For first-degree relatives, avoid exogenous estrogens and always tell healthcare staff if your family history if you're admitted, going for an operation or become pregnant, because they may wish to consider thromboprophylaxis. The other important point is many insurers don't ask about family history of blood clots, but they do ask about genetic tests. Therefore, thrombophilia testing may adversely affect insurance premiums.
So, Mark, cancer is a risk factor for clots. Do we need to screen patients with clots for cancer?
You're right. About 10% of patients with a clot then go on to develop cancer in the following year. Lots of studies have been performed looking at whether screening for cancer is beneficial. Apart from a good history and examination and a chest x-ray in a smoker, routine scanning or tumour markers have not been shown to be beneficial. But obviously you should have a low threshold for further investigation.
Okay. Occasionally we see clots other than DVTs and PEs. Should these be handled any differently?
Upper limb thrombosis, unless associated with thoracic outlet obstruction, very rarely tend to recur, therefore they don't need further investigation. Similarly, cerebral venous thrombosis have a low risk of recurrence. Although the majority of these unusual thromboses tend to be provoked, for example Crohn's disease causing mesenteric thrombosis, they can be due to rare thrombophilic diseases. I would recommend testing for antiphospholipid syndrome, unexplained arterial thromboses under 50, and where women have 3 or more unexplained spontaneous miscarriages, 1 or more fetal loss, severe or early preeclampsia, or unexplained placental insufficiency. In addition to testing for antiphospholipid syndrome, patients should also be tested for PNH and have myeloproliferative disease excluded by performing a full blood count and JAK2 test if they have a clot at an unusual site or if they suffered from both arterial and venous clots.
Thanks very much, Mark. In summary, what are some of the key messages to bear in mind?
I think when deciding on the length of anticoagulation in a patient who's had a blood clot, the important points to remember are whether the event was provoked or unprovoked, what the bleeding risk of the patient is if they were to continue an anticoagulation, the likelihood of significant morbidity and mortality if that patient was to have a recurrent event, and that inherited thrombophilia testing is not useful either for the patient or their family.